If a wounded combat casualty, takes a bullet or shrapnel on a modern battlefield,
Right.
and they actually manage to make it through the doors of a medical treatment facility alive, their survival rate is over 95%.
It really
I
is.
mean, let that number sink in. 95%.
It's a staggering statistic, honestly, because, well, when you consider the sheer destructive power of modern weaponry.
Oh, yeah. The ballistics, the blast waves.
Exactly. High-velocity rounds, improvised explosive devices. You're dealing with polytrauma that just crushes bones and completely ruptures organs.
Yeah.
So the fact that surgical teams can save, 19 out of 20 patients who actually reach their operating tables,
Yeah.
it's really one of the greatest achievements of modern medicine.
It is. I mean, it's an absolute miracle of logistics and science.
Mm-hmm.
But, and here's the dark reality of combat medicine, right? And it's the whole reason we are doing this deep dive today. People are still dying. Casualties are still being lost at terrible rates. And if they aren't dying in the hospital, well, that begs a very grim question. Where exactly are the fatalities happening?
They're dying in the dirt.
Yeah.
They are bleeding to death in that terrifying, just chaotic window of time between the moment the injury occurs and the moment that helicopter finally touches down at the hospital.
Which means all of that perfect, sterile medical technology that we always associate with saving lives.
Right. The bright surgical lights, the climate control.
Exactly. The endless supply of clean blood. All of that is utterly useless to the people who never actually make it there.
It's totally inaccessible to them.
So today, for you listening, we're looking at an absolute masterclass in extreme problem solving. We're diving into a 2016 analysis.
By Jamison S. Nielsen and Justin Watson.
Right, from Current Trauma Reports.
Right.
And it details how modern medicine had to completely throw out its own rulebook to save the people bleeding out in the mud.
It really is a complete paradigm shift. Because for decades, the instinct of any highly trained surgeon or, medical provider was to just fix the anatomical damage immediately.
Like find the hole and patch it.
Right. Find the tear, meticulously sew it up, and try to restore the patient's anatomy to its original perfect state.
Which makes sense in a normal hospital.
It does. But in a war zone, trying to execute that kind of perfect repair, it will actually kill the patient.
So if you can't fix the injury, what do?
You practice damage control resuscitation, or DCR.
DCR, right.
You basically abandon the whole idea of anatomical perfection, and instead you engage in this desperate, highly calculated negotiation with the human body just to keep its chemistry from shutting down.
Wow.
Yeah, you intervene just enough to stop the bleeding, and then you deliberately delay the definitive surgical repair until the patient is stable enough to actually survive it.
Okay, let's unpack this, because you are essentially saying that treating the specific injury takes a backseat to treating the whole system. And to really understand why that is so critical, we need to step away from that 95% survival rate in the hospital and look at the pre-hospital environment.
Right.
Because according to the data Nielsen and Watson analyzed, 87% of potentially preventable combat deaths occur before the patient ever sees a hospital.
87%.
It's wild. And the vast majority of those are due to exsanguinating hemorrhage.
Which is really just the clinical term for bleeding to death.
Right.
And it happens so frequently because these injuries occur in what the medical community calls an austere environment.
Austere environment. Which sounds like a very polite way of saying an absolute nightmare scenario.
Yeah, that's exactly what it is. An austere environment means you have zero control over the external world.
None at all.
You're dealing with ongoing firefights, which means you can't even stand up, let alone set up a sterile field.
Right.
You're dealing with extreme thermal stress. Maybe it's, 115 degrees in a desert or freezing rain on a mountainside.
And your supplies are just whatever you can carry.
Exactly. Your entire medical supply closet is limited to whatever you could physically strap to your back.
And on top of all of that, the injuries themselves are catastrophic. I mean, we aren't talking about a clean surgical incision here.
No, not at all.
We are talking about blast force polytrauma.
Right. And a blast wave doesn't just cause one neat little wound. It throws the body against a wall, breaking the pelvis.
And it drives shrapnel into the limb.
Yes. And the concussive overpressure literally tears the tiny air sacs in the lungs. So you have multiple massive traumas occurring simultaneously.
It's just massive systemic shock.
Mm-hmm. And when the body experiences that level of trauma and starts losing huge amounts of blood, it triggers a biological cascade that medics refer to as the lethal triad.
A lethal triad. Man, when I was going through the source material, this concept completely changed how I view trauma.
It really reframes everything, doesn't it?
It does, because we tend to think that the bullet hole or the shrapnel wound is what ultimately kills you. But once this triad starts, the injury is almost secondary. Your own body essentially turns against you. So let's break this down, because it is both fascinating and terrifying.
Okay.
What are the three parts of the lethal triad?
Well, the three components are hypothermia, acidosis, and coagulopathy.
Okay.
And the real nightmare of the lethal triad is that these aren't just three separate problems. They feed into each other in this vicious, self-sustaining loop.
A death spiral.
Exactly. Let's start with hypothermia.
Getting dangerously cold.
Yes. Now, when we think of body heat, we usually think of muscle movement or, shivering.
Right.
But your blood is actually the radiator fluid of your body. It carries warmth from your core out to your extremities.
Oh, wow. I never thought of it like that.
Yeah. So when you lose a massive volume of warm blood, you are literally bleeding out your thermal mass.
So you just can't hold heat anymore.
Right. Add to that the fact that the casualty might be lying on cold dirt, their clothes have been cut open by medics, they're exposed to the wind.
And their core temperature just plummets rapidly.
Exactly.
So the body is basically freezing from the inside out because the radiator fluid is gone.
That's a perfect way to put it. And as the body gets cold and as blood pressure drops because the pipes are emptying out, your tissues are no longer receiving enough oxygen.
Because the red blood cells just aren't arriving.
Right. And this leads directly to the second part of the triad, which is acidosis.
Acidosis, the blood becoming acidic. How exactly does a lack of oxygen cause acid to build up in the blood?
It all comes down to cellular metabolism. On a normal day, your cells take in oxygen and glucose, and they use aerobic metabolism to create energy.
Okay, so that's the normal clean process.
Exactly. It's highly efficient. But when a trauma patient is bleeding to death, their cells are starving for oxygen.
Because the blood isn't getting there.
Right. So to survive, the cells are forced to switch to an emergency backup system called anaerobic metabolism.
Anaerobic meaning without oxygen.
Correct. And anaerobic metabolism is incredibly inefficient. Plus, it produces a toxic byproduct, which is lactic acid.
Oh, so that's where the acid comes from.
Yes. As millions of starving cells all across the body start dumping lactic acid into the bloodstream, the blood's pH drops, and the patient becomes acidotic.
So the patient is rapidly freezing and their blood is turning acidic. I mean, that sounds fatal just on its own.
It is incredibly dangerous.
But this is a triad. There's a third element that actually makes the bleeding accelerate, right?
Yes, and that is coagulopathy. This is really the absolute core of the crisis. Coagulopathy is the failure of the blood to clot.
Meaning you just keep bleeding.
Exactly. And this happens directly because of the hypothermia and the acidosis we just talked about.
Walk me through the mechanics of that. Why does being cold and acidic stop a clot from forming? I feel like we just assume blood always clots.
Right, but you have to think of a blood clot not as a simple scab, but as a highly complex, multi-step construction project.
Okay.
Your blood is full of these floating proteins and enzymes called clotting factors. When you get cut, these factors have to link together in a very specific cascading sequence to build a mesh of fibrin over the hole.
To plug the leak.
Yes, but these enzymes are incredibly fragile.
Mm-hmm.
They are biological machines that evolved to operate perfectly at exactly 98.6 degrees Fahrenheit and at a perfectly neutral pH of 7.4.
Ah, okay, I see where this is going.
No.
So it's like trying to run an engine with the wrong oil in freezing weather?
That is exactly it. When the patient's temperature drops, those chemical reactions slow down to a crawl. The enzymes literally become sluggish.
And the acid.
When the blood becomes acidic, the acid physically denatures the proteins. It warps their shape. So the lock and key mechanisms of the clotting cascade just don't fit together anymore.
That is incredible. So the colder and more acidic you get, the less your blood can physically clot.
Right.
Which means you bleed faster.
Mm-hmm.
Which means you lose more radiator fluid, so you get even colder, and you lose more oxygen, so you get even more acidic.
Which then destroys even more of your clotting ability. It truly is a biological death spiral. And what's fascinating here is that the clinical data shows coagulopathy isn't just something that happens at the very end of dying.
Wait, really?
Yeah. The acute coagulopathy of trauma, or ACT, is present in at least 25% of severely injured patients the moment they arrive at medical care.
The moment they arrive.
Yes. And if they have a severe traumatic brain injury, it's present up to 60% of the time.
So this isn't just a slow, gradual process. The body is actively breaking its own ability to clot almost immediately.
It happens so fast.
Now, the source material mentioned a few specific terms regarding this that I definitely want to clarify because they sound incredibly complex.
Sure.
They talk about hyperfibrinolysis and the endotheliopathy of trauma. Let's start with the endothelium. What is that, and how does trauma break it?
So the endothelium is a microscopically thin layer of cells that lines the entire inner surface of your blood vessels.
Like a lining.
Exactly. Think of it as a nonstick Teflon coating for your arteries and veins. Its normal job is to keep the blood flowing smoothly and prevent clots from forming where they shouldn't.
Okay, that makes sense.
But when a massive injury occurs, the shock wave, the lack of oxygen, and that sudden drop in pressure cause the endothelium to become profoundly dysfunctional.
So the Teflon coating gets damaged.
It does worse than get damaged. It goes haywire. A healthy endothelium releases specific signals to tell platelets exactly where to stick when there's a cut.
Right.
An injured, starved endothelium loses the ability to coordinate that response.
Yeah.
It sheds its protective layer. And in response to the massive trauma, the body panics and triggers hypofibrinolysis.
Okay, let's break that word down because fibrin is the mesh that holds a blood clot together, right?
Yes.
And lysis means to break down or destroy. So hyperfibrinolysis means the body is aggressively destroying its own fibrin.
Exactly. Your body always maintains a balance between building clots and breaking them down, just so your veins don't fill up with solid blood on a normal day.
Which would be bad.
Very bad.
Yeah.
But in severe trauma, the body's neurohumoral system, the deep brain stress response, dumps massive amounts of clot-busting enzymes into the bloodstream.
Oh, man.
So even if that cold, acidic blood miraculously manages to build a fragile clot over a severed artery, the body's own hyperactive enzymes swoop in and aggressively dissolve it.
So the body is actively working against you. The enzymes are sluggish from the cold, they're warped by the acid, and the few clots that do form are being eaten alive by the body's own panic response.
Right. That is the acute coagulopathy of trauma. But as devastating as that is, there's another type of coagulopathy detailed here that is, in many ways, much more tragic.
More tragic than your body eating its own clots.
Yes, and that is IC, iatrogenic coagulopathy.
Iatrogenic, meaning caused by the medical treatment itself.
Yes. For a very long time, the standard medical doctor, what medics and civilian paramedics were taught as absolute gospel,
Right.
was that if a patient was bleeding and their blood pressure was dropping, the immediate fix was to pump them full of clear, crystalloid IV fluids, the most common being normal saline.
Just standard IV fluids.
Exactly. The logic was purely mechanical. The tank is leaking, the pressure is dropping, so we must refill the tank with liquid to get the pressure back up to normal.
So they would hang bags of room temperature salt water and just flood it into the patient's veins.
Right.
But based on what we just discussed about the lethal triad, doesn't that make everything worse?
It accelerates the death spiral exponentially.
Yeah.
And it took the medical community a long time to accept just how dangerous this practice actually was.
Let's walk through exactly why pumping saline is a death sentence for these casualties. So first, the temperature.
Right. If you take a casualty who is already shivering in the dirt and you pump liters of room temperature saline, which might be, 70 degrees Fahrenheit, directly into their core circulation.
You induce massive, immediate hypothermia.
You're literally freezing them from the inside.
Strike one. What about the acid? You said saline is salt water.
Normal saline has a pH of around 5.5, so it is inherently acidic.
Wow.
Yeah, so when you push it into an already acidotic patient, you are actively driving their pH down even further, directly warping their clotting proteins.
Strike two. And strike three has to be what it does to the blood itself. Like if you have a bucket of red paint and you pour a gallon of water into it, you don't have more paint.
Exactly.
You just have watery, useless pink liquid.
That is a perfect analogy. The saline dilutes the blood. It washes out the remaining red blood cells, which means even less oxygen is getting to the tissues.
Right.
And it dilutes the precious few clotting factors the patient has left. So the blood becomes too thin to clot. And to make the physics of it even worse, by filling the tank with saline, you artificially raise the blood pressure inside the vessels.
Wait, so you are thinning out the blood, destroying its ability to clot, and then increasing the hydraulic pressure behind it,
Right.
which just pushes that watery blood out of the bullet hole even faster. It's like trying to put out a grease fire by pouring a bucket of water on it. You think you're helping because it's a liquid, but you're actually destroying the entire chemical environment and spreading the destruction.
That realization that our own medical interventions were killing people by inducing iatrogenic coagulopathy is what birth damage control resuscitation.
Wow.
DCR is a total uncompromising rejection of that old pump 'em full of saline model.
Which means the medics out in the field had to completely change how they operate.
Completely.
If they can't just slap an IV in and flood the patient with fluids, what do they actually do while the bullets are literally flying?
Right.
And this brings us to a highly regimented protocol called Tactical Combat Casualty Care, or TCCC.
Yes, TCCC. It was developed specifically because civilian medical protocols simply get people killed on a battlefield.
Right.
It is a strict, phased approach that dictates exactly what a provider can and cannot do at the point of injury, based entirely on the tactical situation.
Right, because if you or I take a standard Red Cross first aid class, the very first thing they drill into your head is the ABCs, right? Airway, breathing, circulation.
Right, always the ABCs.
If someone collapses, you check their airway first. You tilt their head back, you see if they're breathing. But in TCCC, the first phase is called care under fire. And the rules of medicine are completely inverted here.
They really are. In care under fire, airway management is deliberately, aggressively ignored.
Hold on, you're telling me a medic runs up to a casualty who might be choking on their own blood or not breathing at all, and they intentionally ignore the airway?
Yes.
How is that justifiable?
Because of the tactical reality.
Yeah.
In care under fire, the absolute first priority is not medical at all. It is scene safety.
Meaning the bad guys.
Exactly.
Yeah.
The best medicine on a battlefield is fire superiority.
Yeah.
If a medic stops to meticulously open a patient's airway while a machine gun is actively targeting them, that medic will be shot.
Oh, wow.
And now you don't have one casualty, you have two. And absolutely no one to save either of them.
So what are they actually authorized to do in that first phase?
Return fire. Tell the casualty to seek cover. Instruct the casualty to apply their own tourniquet if they are bleeding from an extremity.
And if they can't?
If the casualty can't do it, the medic might quickly slap a tourniquet high and tight over the uniform, and then they grab the patient and drag them off the X-unit, get out of the kill zone.
Just grab and go.
That is it. You do not check a pulse, you do not check breathing, you stop catastrophic bleeding, and you move. Because an airway intervention takes time, and if their femoral artery is severed, they will bleed to death in 3 minutes anyway. Circulation takes precedence.
It's ruthless, but I mean, it makes perfect logical sense. Survival dictates the steps.
Exactly.
So assuming they survive phase 1 and they manage to drag the casualty behind a wall or into a ditch, they transition to phase 2, which is tactical field care.
Right. They are out of the immediate line of fire, though they are still in a highly dangerous, austere environment. And this is where the medic actually goes to work. The tools they use here are specifically designed to combat exsanguination without using massive fluid volumes.
Let's talk about those tools. We all know what a tourniquet is.
Right.
I think the military uses the Combat Application Tourniquet, or CA.
Yes, that's the ECT.
You wrap it, twist the windlass rod, and mechanically crush the artery against the bone to stop the flow. But what about wounds where you just can't use the tourniquet?
Right.
The analysis mentions something called combat gauze.
Combat gauze is a brilliant innovation. It looks like standard medical gauze, but it is impregnated with an inorganic mineral called zeolite.
Zeolite, like the clay.
Yes, zeolite has a highly porous microscopic structure. So when you pack combat gauze deeply into a bleeding wound, the zeolite acts like a sponge. It rapidly absorbs the water content from the blood.
Oh, wow. So by sucking the water out of the blood locally, right inside the wound, it leaves behind a super concentrated sludge of red blood cells and clotting factors.
Precisely. It artificially creates a localized, highly concentrated clotting environment right at the site of the bleeding vessel. So it speeds up the cascade, even if the patient's core temperature is dropping.
That is so smart.
And alongside the gauze, the medic will also administer a drug called tranexamic acid, or TXA.
TXA, how does that fit into the picture?
Remember our discussion about hyperfibrinolysis, the body panicking and aggressively dissolving its own clots?
Yeah, the self-destruct mode.
Right. TXA is an antifibrinolytic. When injected, it binds to the enzymes that dissolve clots and neutralizes them. It essentially tells the body to stop destroying the life-saving plugs the medic is trying to build.
So you have tourniquets for the limbs, zeolite clay gauze to concentrate the blood in the wounds, and TXA to stop the body from tearing down the clots.
It's an incredibly sophisticated biological defense system.
It really is. But there is another protocol in phase 2 that completely shocked me, and it's a behavioral protocol, not a chemical one.
You're referring to the protocol regarding altered mental status.
Yes. The analysis explicitly states that if a medic reaches a patient in tactical field care and the patient has an altered mental status, meaning they are confused, delirious, maybe concussed from a blast wave,
Right.
the very first medical step is to disarm them. They take away your weapon and their communications gear.
It's an incredibly stark reminder of the reality of their environment.
I just want you, the listener, to imagine the psychology of that moment. You go to medical school or you train as a paramedic, and your instinct is to comfort the patient, to say, "Stay with me, buddy, look at me."
Yeah.
But here, the protocol demands that you treat the patient as a potential lethal threat to yourself.
You have to. A patient in hemorrhagic shock is not thinking rationally. Their brain is severely deprived of oxygen. They are in an extreme state of hypoxia-induced fight or flight.
Because they're suffocating.
Exactly. So if they wake up confused in the middle of an active war zone, surrounded by loud noises and people grabbing at them, their instinct might be to raise their rifle and start shooting wildly. Securing the patient's weapon isn't just a safety protocol. It is a life-saving medical intervention that ensures the medical team survives long enough to actually treat them.
It just highlights the immense cognitive load on the medic. They aren't just fighting the lethal triad, they are fighting the environment and sometimes the patient themselves. So once the bleeding is temporarily controlled and the patient is secured, we move to phase 3, which is tactical evacuation care.
This is the critical transition phase. Because the goal of TCCC is not to keep the patient in the dirt. It's to get them to that forward surgical team where the 95% survival rate lives.
Right, get them to the hospital.
The analysis distinguishes between two main types of evacuation. Medevac, which uses dedicated medical platforms like a Black Hawk helicopter specifically outfitted with medical gear and trained flight medics.
And the other is PACEvac, right? Casualty evacuation?
Yes. CaseEvac basically being the throw them in whatever vehicle has an engine method.
Like a supply truck or Humvee.
Exactly. It's an extraction of desperation. But regardless of the vehicle, initiating that evacuation requires a highly structured communication protocol known as the 9-line medical evacuation request.
The 9-line. I want to spend a moment on this because it's a fascinating study in how human beings process information during a crisis.
It really is.
When a medic radios for a helicopter, they don't just pick up the handset and yell, "We have a guy bleeding out, send a bird." They transmit a highly rigid, universal code.
The 9-line is a marvel of information triage. It forces the person on the ground, who is likely terrified and operating under extreme cognitive stress, to provide the most vital information in a specific, prioritized sequence.
Right, so line 1 is the pickup location, the GPS coordinates. Line 2 is the radio frequency and call sign. Line 3 is the number of patients by precedence, how urgently they need care.
Right.
Notice what isn't there in the first 3 lines.
The patient's actual medical condition.
Exactly. They don't even mention that the patient is missing a leg or has a chest wound until much further down the list. Why is the medical data secondary?
Because of the reality of combat communication.
Yeah.
Radios fail, batteries die, antennas get shot.
Everything breaks.
Exactly. If the medic gets on the radio and starts by frantically describing a complex gunshot wound to the abdomen, and 5 seconds later the radio battery dies, the helicopter pilot has absolutely no idea where to fly to save them.
Oh, man.
By front-loading the location and the radio frequency, the 9-line ensures that even if communication is immediately severed, the pilot knows exactly where to go and how to try and hail them on a backup channel when they get close. It mitigates the chaos of the environment.
It's all about accepting that the system will fail and building protocols that survive the failure.
Perfectly said.
Which perfectly transitions us to the next major medical hurdle. We've talked about using tourniquets to stop bleeding on the arms and legs, but what happens when the injury is somewhere you absolutely cannot wrap a belt around?
This is known in trauma literature as non-compressible torso hemorrhage, or NCTH.
Okay.
And historically, it has been the ultimate unsolvable resuscitative dilemma. If a soldier takes a high-velocity round or shrapnel to the deep abdomen, the groin, or the axillary region, the armpit,
Right.
you simply cannot apply a traditional tourniquet.
And as we discussed with the combat gauze, you can try to pack the wound, but if it's a major artery deep inside the pelvic cavity, shoving gauze into a cavernous space isn't going to exert enough pressure to stop a high-pressure arterial bleed.
Exactly. The blood will simply flow around the gauze and fill the abdominal cavity.
So what do they do?
To combat this, Researchers and engineers have developed interventions that sound like they belong in science fiction.
Seriously.
The first is an external device called the abdominal aortic and junctional tourniquet, or the AJT.
The AAJT. Explain the mechanics of this because it sounds incredibly brutal.
It is brutal, but it is better than exsanguination.
Fair point.
The aorta is the massive main pipe that carries blood from your heart down through your torso to feed your lower body. If an artery in the pelvis or groin is shattered, you need to turn off the main water valve upstream.
Okay.
The AEJT looks like a very wide, heavy-duty utility belt. The medic wraps this belt completely around the patient's abdomen, right over the umbilicus, and cinches it tight using a windlass mechanism.
Wait, just tightening a belt around someone's stomach isn't going to stop the blood flow deep inside against the spine, right?
No, which is why the AEJT incorporates a targeted, inflatable pneumatic bladder.
Ah.
Once the belt is tightly secured, the medic uses a hand pump to force air into this bladder. The bladder expands inward, driving a wedge of immense localized pressure directly down through the abdominal wall, through the intestines, and literally crushes the descending aorta flat against the patient's spine.
Wow. So it acts as an external clamp for the body's main blood pipe. It just flattens the aorta against the bone to physically block the blood from reaching the shattered pelvis below.
Precisely. It is an extraordinary application of physics to solve an anatomical problem.
It really is.
But the analysis also highlights a second innovation for non-compressible hemorrhage that is even more radical.
Oh, right.
Intra-abdominal self-expanding polyurethane foam.
I read this part 3 times to make sure I was understanding it correctly. They're injecting expanding plastic foam into people's bodies.
Yes. When external compression like the AHAT isn't viable, or the bleeding is widespread throughout the abdominal cavity, researchers have developed a specialized dual-chamber liquid polymer.
Okay.
The medic takes a device that looks somewhat like a large caulk and gun, inserts the nozzle directly into the patient's abdominal wound or a small surgical incision, and pulls the trigger.
And the two liquids mix as they enter the body.
Exactly. As the two chemical components mix inside the warm environment of the patient's abdomen, they trigger a rapid exothermic chemical reaction.
Meaning it gets hot.
Yes, and the liquid almost instantly expands to up to 30 times its original volume, transforming into a dense, solidifying polyurethane foam.
So it's exactly like that expanding spray foam you use to seal cracks around a window frame in your house.
Conceptually, yes, but highly engineered for human biology. The foam rapidly expands to completely fill the entire abdominal cavity.
Just fills the whole space.
It flows around the intestines, the liver, the spleen, and molds precisely to the exact contours of the internal organs and, crucially, the site of the shattered blood vessels.
Which creates a massive internal plug.
We call it a massive internal tamponade. It applies uniform, perfectly contoured pressure against all the bleeding vessels from the inside out. It physically locks the organs in place and stops the hemorrhaging.
But wait, I have to push back on this. You just pumped hardening plastic foam into someone's stomach. It hardens around their intestines.
Right.
How on earth does a surgeon fix that once the patient gets to a hospital? Don't they have to chisel it out?
It presents a unique challenge for the surgeon, certainly. Once the patient reaches the forward surgical team, the surgeon performs a laparotomy. They open the abdomen fully. The foam is designed to be cohesive, meaning it sticks to itself better than it sticks to wet human tissue. So the surgeon physically scoops, peels, and cuts the solid block of foam out of the cavity.
That sounds intense.
It adds time to the surgery. But the critical factor is that the foam bought the patient the one thing they didn't have: time.
Right.
In dramatic swine models, this foam has shown a massive survival advantage for otherwise lethal iliac artery injuries. It stops the clock.
It truly is the ultimate manifestation of damage control. We aren't fixing the artery, we are just filling the entire cavity with expanding plastic so you don't die in the helicopter.
Exactly.
But even with these incredible tools, the foam, the junctional tourniquets, the Z-like gauze, the patient has still lost a massive volume of blood before the medic ever arrived.
Yes, their volume's depleted.
The tank is low. And we established earlier that refilling the tank with saline is a death sentence because it blows out the clots and dilutes the blood.
Right.
So how do medics actually manage the patient's blood pressure in the field?
They utilize a highly counterintuitive doctrine called permissive hypotension.
Permissive hypotension, meaning permitting the blood pressure to stay dangerously low.
Exactly. The old mindset, rooted in civilian medicine, was that low blood pressure meant the patient was crashing, and the provider must aggressively push fluids to normalize it back to 120/80.
Because that's normal.
But in trauma, a low blood pressure is often the body's protective mechanism.
Let's build an analogy here. Imagine you have a pressurized water main under a city street and it bursts.
Okay, a water main break.
If the city engineers want to patch that massive hole, the very first thing they do is turn down the water pressure at the pumping station, right?
They have to.
Because if they try to weld a fragile metal patch over the hole while the water is blasting at maximum pressure, the hydraulic force will just blow the patch right off.
Absolutely.
The body is doing the exact same thing. It is lowering its own pumping pressure so that those fragile little fibrin clots we talked about earlier have a chance to stick to the hole in the artery.
That is a brilliant way to conceptualize it. If a medic aggressively pumps fluids into the patient to force their blood pressure back up to normal, that sudden surge of hydraulic pressure will literally blow the fragile, newly formed clots right off the damaged vessels.
Destroying the fix.
Yes, and the catastrophic internal bleeding starts all over again. This is clinically known as popping the clot.
Popping the clot. That is a terrifying phrase.
So instead of aiming for normal, the medics practice permissive hypotension. They deliberately aim for a systolic blood pressure of just 80 to 90 millimeters of mercury.
That's super low.
This is extremely low. It is right on the razor's edge of shock.
Yeah.
But in the field, where medics don't have electronic monitors, they are taught a very simple physical metric.
How do they measure it without machines?
They feel for a radial pulse.
How?
If you place your fingers on a patient's wrist and you can feel their heartbeat, their systolic pressure is roughly 80. If they only have a pulse in their neck, a carotid pulse, it's too low. So the medic will slowly drip in just enough life-saving fluid until the radial pulse returns at the wrist, or until the patient's mental status improves enough that they can answer simple questions.
This is the bare minimum.
The moment they hit that absolute minimum baseline, the medic stops pushing fluids.
They ride the razor's edge, keep the pressure just high enough to ensure the brain and the kidneys don't die from oxygen starvation, but low enough to avoid popping the fragile clots in the abdomen.
It is a terrifying balancing act.
It sounds like it. But there is one major critical exception to this rule of keeping the blood pressure low, isn't there?
Yes, traumatic brain injury, or TBI. If the medic suspects the casualty has suffered a severe head injury, perhaps from the overpressure of a blast wave, the entire protocol changes.
Why does a brain injury change the blood pressure targets for the rest of the body?
Because of the unique anatomy of the skull. The brain is housed inside a rigid, unyielding, bony box. If you break your arm, the tissue swells outward. But if the brain is injured and begins to swell, or if there is bleeding inside the skull, it has nowhere to go. The swelling increases the intracranial pressure inside the skull.
So the pressure inside the box is rising.
Exactly. And the heart has to pump oxygenated blood up the neck and into that highly pressurized box.
Oh, I see.
If the systemic blood pressure is too low, if the medic is holding the pressure at 80 using permissive hypotension, the heart simply will not have enough driving force to push blood against the rising pressure inside the skull.
Because it's fighting a higher pressure.
Yes, and the brain tissue will be starved of oxygen and it will rapidly die.
It's an agonizing trade-off.
It is the worst-case scenario for a provider. If a TBI is present, the medic must abandon permissive hypotension. They're forced to push fluids to raise the systolic blood pressure to at least 90, sometimes 110, to guarantee cerebral perfusion.
Wow.
They are knowingly trading the high risk of popping internal clots and restarting the bleeding in the torso in order to save the brain from suffocating.
That decision matrix is just, it's heavy.
It really is.
So let's say they've stopped the massive bleeding with tourniquets or foam, and they're managing the low blood pressure perfectly. They still need to give the patient some kind of fluid because the tank is dangerously empty.
Yes.
We know saline is a death sentence because it causes the lethal triad. So what fluid are they actually pushing into the casualty's veins? And this brings us to a massive logistical and scientific war over blood.
It is a logistical war because every trauma surgeon in the world agrees on what the absolute perfect resuscitative fluid is.
What is it?
It is exactly what the patient is bleeding out. Fresh whole blood.
Fresh whole blood, not parts of blood, the whole thing.
Yes, whole blood is a miracle substance that we cannot artificially replicate. It contains intact red blood cells that act as cargo ships, carrying massive amounts of oxygen to starving tissues.
Right.
It contains a full complement of active, warm platelets and procoagulant factors that instantly get to work, building clots. And it contains oncotic proteins like albumin, which exert osmotic pressure to pull water back into the blood vessels and keep the blood volume stable.
It's the perfect drug. So why isn't every medic just running around with bags of whole blood in their backpack? Problem solved, right?
Because whole blood is a biological nightmare to manage in an austere environment. It requires a flawless cold chain.
A cold chain, meaning it has to be kept perfectly refrigerated from the moment it leaves the donor to the moment it enters the casualty.
Exactly. If it gets too warm, bacteria rapidly multiply and the proteins degrade. If it gets too cold and freezes, the red blood cells physically shatter.
Oh, wow.
So maintaining a perfect refrigerator in a backpack during a 3-day patrol in a 110-degree desert is technologically nearly impossible. Furthermore, whole blood has a very short shelf life measured in weeks.
What about walking blood banks, taking blood from a healthy soldier right there in the dirt and giving it to the wounded one?
The military does train for that, but it is fraught with risk. Using fresh whole blood in the field requires rapid, perfectly accurate screening protocols to ensure the donor doesn't have HIV, hepatitis, or other bloodborne pathogens.
Which you can't really do during a firefight?
You can't easily do those complex lab tests under fire, no.
Hmm.
So the military needed a fluid that had the clotting power of blood, but the logistical durability of a bottle of water.
And the answer to that impossible demand is something called lyophilized plasma, or LP.
Yep.
Essentially freeze-dried plasma.
Yes. Plasma is the liquid, golden-colored portion of the blood. If you filter out all the red blood cells, you are left with plasma, which contains all the vital clotting factors, proteins, and enzymes we talked about earlier.
Okay.
By putting this plasma through a process of lyophilization, freeze-drying it under a vacuum, researchers can extract all the water, leaving behind a stable, dry powder.
So you have powdered blood plasma.
Exactly. And this completely revolutionizes the logistics. Lyophilized plasma doesn't need a cold chain. It can sit in a backpack in the desert heat for up to 2 years without degrading.
That's incredible.
When a casualty is bleeding out, the medic simply takes a plastic bag of the yellow powder, connects it to a bag of sterile water, mixes them together, and within 3 minutes, they have a highly potent resuscitative fluid.
And because it's actual plasma, it doesn't dilute the blood like saline. It actively replaces the clotting factors, directly fighting the acute coagulopathy of trauma.
Right.
But what I found absolutely mesmerizing in the historical background of this analysis is that this isn't a new invention.
Not at all. The military actually used freeze-dried plasma extensively over 80 years ago.
Right. The analysis points out it was deployed on a massive scale during World War II. It saved countless lives on the beaches of Normandy and in the Pacific Theater.
Yes, it did.
But then, right after the war, the military completely abandoned it. For decades, it was blacklisted. Why did they throw away a miracle drug?
It is one of the great tragic ironies of medical history. The military abandoned it because of a devastating unintended medical disaster.
What happened?
Well, during World War II, to meet the massive demand for plasma, the blood banks were pooling donations from tens of thousands of individual citizens. They would dump thousands of donations into massive vats, mix it all together, and then freeze-dry it in bulk batches.
Because it was faster and cheaper to do it in bulk.
Yes. But in the 1940s, our understanding and testing of viral pathogens was incredibly rudimentary. We didn't have the screening tools we have today.
Oh, no.
And because of the math of pooling thousands of donors into a single batch, if even one single person in that entire pool was an asymptomatic carrier of hepatitis, the entire batch became contaminated.
So they were mass-producing infected plasma.
They inadvertently transmitted hepatitis to a massive number of American troops. The outbreak was severe enough that the military concluded the systemic risk of viral transmission outweighed the resuscitative benefits. They shelved freeze-dried plasma entirely. And for decades, that stigma held back trauma medicine, forcing providers to rely on those deadly saline bags.
A life-saving intervention completely sidelined by a secondary pathogen. It's heartbreaking to think how many lives might have been saved in later conflicts if they had kept developing it. But as this analysis shows, it is finally back.
It is back because modern single-donor processing, advanced viral screening, and pathogen reduction technologies like treating the plasma with UV light have virtually eliminated the risk of disease transmission.
Oh, it's amazing.
The analysis specifically notes a heavy modern reliance on 2 European products, German Lyoplast and French Fly P.
Right.
The German military has conducted over 230,000 transfusions of Lyoplast since 2007, and their data shows the safety profile is completely equal to standard frozen plasma in civilian hospitals.
But military medicine isn't just satisfied with bringing an old tool back. They are actively trying to hack the biology to make it even better. And this leads to some incredibly strange, cutting-edge science mentioned in the text involving pigs and vitamin C.
Yes, the optimization phase of lyophilized plasma is where the science gets deeply granular and fascinating. The researchers are using severe traumatic swine models, using pigs, because a pig's cardiovascular and clotting systems are remarkably similar to human physiology.
Right. Pigs are often used for this.
Exactly. They realize that when the medic mixes the dry plasma powder with liquid in the field, it doesn't just have to be plain water.
They can mix other chemical agents into the reconstitution fluid.
Exactly. And one of the most promising agents they tested was ascorbic acid, which is vitamin C.
Okay, I have to ask, why vitamin C? I mean, we take it when we have a cold, but what does it do for a soldier who has just stepped on an IED?
To understand this, we have to look at the cellular damage of trauma. When cells are violently torn open, crushed, and starved of oxygen, they undergo immense oxidative stress.
Okay.
In their panic, the damaged cells release massive amounts of reactive oxygen species, or free radicals.
Free radicals. These are unstable molecules that run around damaging other healthy cells.
Yes, they cause a massive wave of dysfunctional systemic inflammation that damages the endothelium, that Teflon coating of the blood vessels we discussed earlier.
Right, breaking down the lining.
It turns out that ascorbic acid is a profoundly powerful antioxidant. The swine studies show that when they reconstituted the freeze-dried plasma with ascorbic acid, the vitamin C swept through the bloodstream, neutralized the free radicals, and actively protected the cellular DNA from oxidative damage.
Wait, so they aren't just replacing blood volume, they are chemically engineering the fluid to actively calm down the body's cellular panic attack.
Precisely.
That is incredible. And the analysis mentioned another optimization, making the plasma hyperosmotic. What does that mean?
Hyperosmotic or hypertonic means making the fluid highly concentrated with solute salts and proteins. If you inject a highly concentrated hyperosmotic plasma into a patient's vein, it exploits the rules of osmosis. The high concentration of proteins in the blood vessel acts like a magnet, rapidly pulling water out of the surrounding muscle and fat tissues and dragging it into the bloodstream.
Oh. So instead of carrying a massive, heavy bag of water to fill up the patient's veins, the medic carries a tiny bag of highly concentrated plasma, injects it, and forces the patient's own body water to move into the blood vessels to raise the blood pressure.
Exactly. The researchers found that by using this hypertonic formulation, the medic could achieve the same life-saving hemorrhage control using 50% less liquid volume.
Half the weight for the medic to carry on their back with added cellular protection against inflammation. It really highlights how the extreme constraints of the battlefield force incredible medical innovation.
It really does.
But even with freeze-dried plasma, once that casualty is loaded onto the medevac helicopter and arrives at the surgical tent, the ultimate goal is still to mimic that perfect substance, whole blood.
Yes. If the surgical team doesn't have fresh whole blood available, they have to recreate it synthetically using separated blood components. And this has led to a massive paradigm shift known as the 1.1.1 ratio.
The 1.1.1 ratio, this is something that has radically changed civilian trauma centers as well, hasn't it?
It has completely rewritten civilian trauma protocols. For a long time, if a car crash victim came into a civilian ER bleeding heavily, the doctors would aggressively pump them full of packed red blood cells.
Just the red cells.
Right. They might give the patient 6 units of red blood cells to carry oxygen, and as an afterthought, maybe give them 1 unit of plasma and 1 unit of platelets.
So they were heavily biasing the resuscitation toward the red blood cells.
Yes. But think of the math. If you dump massive amounts of red blood cells into the body without an equal amount of the plasma and platelets that actually build the clots, you are creating a massive imbalance.
We're diluting the clotting tower again.
Exactly. The patient might have enough oxygen carriers, but they will still bleed to death because they can't clot.
So what did the military data prove?
Through massive landmark studies referenced in the analysis, specifically the PREA-MTT and PROPIOR trials, the military proved that survival drastically increases when you institute a perfectly balanced resuscitation.
So an equal amount of everything.
Exactly. For every 1 unit of packed red blood cells you hang, You must administer exactly 1 unit of plasma and 1 unit of platelets.
1 to 1 to 1.
You are mathematically reconstructing whole blood inside the patient's veins. You provide the volume, the oxygen carrying capacity, and the immediate hemostatic or clotting power all at the exact same time.
So what does this all mean? It is so elegantly simple, yet it took decades of data to prove it. So let's look at where we are in the timeline of our casualty.
Okay.
The medics in the dirt have performed a miracle. They ignored the airway to shoot back. They stopped the extremity bleeding with tourniquets and zeolite gauze. They pumped expanding polyurethane foam into the abdomen. They managed permissive hypotension perfectly to keep the clots from popping, and they stabilized the chemistry using freeze-dried plasma. The casualty has survived the helicopter ride. We now arrive at the forward surgical team. But the chaos isn't over, is it?
Not by a long shot. The chaos just takes a different, highly organized form.
Right.
When that helicopter lands at a forward surgical team, or FST, you have to remember that this is not a limitless, glowing civilian hospital in a major city.
It's still a war zone.
Right. An FST is essentially a series of mobile tents pitched in the dirt. They might only have 4 surgeons, a strictly limited supply of blood in a portable cooler, and limited time before the enemy attacks again.
So what happens if a mass casualty event occurs? Like if an explosive goes off and a helicopter drops off 10 severely wounded, bleeding soldiers at the exact same time?
The system is instantaneously overwhelmed. If all 4 surgeons try to treat the first patient off the helicopter, the other 9 will die. This stark reality necessitates triage.
Triage is a word we hear all the time in everyday life, usually just meaning, sorting things out or prioritizing my email inbox.
Right.
But in military medicine, triage is a ruthless, cold, mathematical system of resource management. The analysis breaks down the 4 distinct categories of triage: immediate, delayed, minimal, and expectant. Let's walk through these because the implications are deeply unsettling.
The immediate category is exactly what it sounds like. These are patients with severe, life-threatening injuries who require surgical attention within minutes to 2 hours.
Okay.
Crucially, they have a high likelihood of survival if they get that surgery now. They are the absolute priority.
Okay, that makes sense. Who is delayed?
Delayed. Patients have severe injuries that absolutely require surgery, perhaps a shattered femur or a deep non-arterial laceration. But their physiological chemistry is stable enough that they can wait a few hours without dying. They are put in a holding pattern.
And the minimal patients?
These are the walking wounded. Minor shrapnel wounds, concussions, sprains. They require very little medical attention, perhaps just a bandage, and can often provide self-care or buddy care to each other.
But the analysis notes something profoundly counterintuitive about these. Minimal patients. In a mass casualty event, the walking wounded can actually be the most dangerous people to the medical system?
They absolutely can. Because human nature in a trauma scenario is to panic.
Sure.
A minimally injured patient who is walking around covered in dust, bleeding from a minor scalp wound, and screaming for a doctor will naturally draw the attention of the nursing staff.
It's human instinct to help the person screaming.
But if a nurse spends 5 minutes trying to calm down a panicking ambular, minimal patient, they are inadvertently diverting incredibly scarce resources away from the immediate patients who are silently bleeding to death on a stretcher nearby.
In an austere environment, attention itself is a consumable supply. You cannot waste a drop of it.
That is a very profound way to put it. Attention and time are your most precious commodities.
Which brings us to the 4th category of triage. And this is arguably the most difficult, heart-wrenching concept in all of medicine. The expectant category.
The expectant category is the grim, unavoidable reality of mass casualty triage under extreme constraints. These are patients with catastrophic, devastating injuries.
Like what?
Massive brain trauma, third-degree burns over 90% of their body, uncontainable core hemorrhaging.
Injuries that are essentially fatal.
Yes, but here is the critical distinction. In a major civilian hospital on a normal Tuesday, a team of specialized trauma surgeons might take that exact same patient into an operating room and fight for 10 hours.
Right.
They might pump 40 units of blood into them, utilizing every piece of technology available to try and secure a 5% chance of survival.
Because in the civilian world, resources are virtually infinite.
Exactly. But at a forward surgical team during a mass casualty event, resources are finite. If the surgical team decides to spend all 4 surgeons, all 10 hours, and all 40 units of blood trying to save that one expectant patient,
They will consume the entire logistical supply of the base.
exactly. And while they are doing that, 5, Immediate patients waiting outside in the triage tent who could have been saved with just 1 hour of surgery and 2 units of blood each will bleed to death.
Wow.
So the mathematics of survival dictate that the medical team must make the agonizing split-second decision to categorize the catastrophic patient as expectant. They must shift from curative care to compassionate palliative care.
Meaning they give them heavy pain medication like morphine, they make them as comfortable as possible, and they let them go.
They do not expend surgical resources on them. They provide comfort, and they move on to the immediate patients.
That's incredibly heavy.
It is the ultimate brutal expression of providing the most benefit to the most people within the constraints present. It requires an immense psychological toll on the triage officers to look a wounded person in the eye and make that call.
I cannot even fathom the psychological weight of making that decision and having to live with it.
It's a tremendous burden.
But let's follow an immediate patient who makes the cut and gets wheeled into the operating tent. This is where damage control surgery, or DCS, officially begins.
Yes, DCS.
The analysis outlines specific physiological triggers that force the surgeon to enter the DCS pathway. If the patient on the table is exhibiting the lethal triad, they are hypothermic, acidotic, or their blood won't clot, the surgeon has to drastically shift their entire approach to surgery.
Yes. If the lethal triad is present, the surgeon is no longer performing a traditional surgery. The goals of damage control surgery are radically simplified and aggressively timed against a ticking clock.
What are those specific goals?
Goal 1. Keep the total operative time under 1 hour. The longer the patient's body is open on the table, the colder they get, and the faster the lethal triad kills them.
Speed is everything.
Goal 2. Limit massive contamination. For example, if a bullet has ruptured the intestines, the surgeon does not spend time meticulously sewing the bowel back together.
What do?
They rapidly staple the ends shut, or simply tie them off just to stop intestinal bacteria from spilling into the bloodstream.
Just tie off the tubes and leave them disconnected.
Exactly. And goal 3 is to control the massive hemorrhage. You don't perform delicate vascular grafts to fix an artery. You throw massive clamps on it, tie it off, or insert a temporary plastic shunt, a literal plastic tube, just to bridge the gap so blood can flow to the leg.
Wow.
You do absolutely nothing definitive. You stop the bleeding, stop the leaking, and you get them off the table and into an intensive care setting so you can warm them up and fix their acidic chemistry.
And the physical reality of what they do to the patient's body during this process is jarring. The text states that in the forward military setting, if a surgeon performs a damage control laparotomy, meaning they slice the abdomen open to get to the bleeding, they almost universally leave the patient's abdomen open at the end of the surgery.
Yes, they do not sew the skin, the muscle, or the fascia back together.
I have to challenge this. You are operating in a dirty tent in a war zone. You've stopped the bleeding, but then you intentionally leave the patient's stomach wide open.
No, it sounds crazy.
Doesn't that guarantee a massive lethal infection? How can leaving a human being open to the air be considered a medical success?
It is highly counterintuitive, but it is physiologically necessary to prevent a condition called abdominal compartment syndrome.
Explain the mechanics of that.
When a human body suffers massive trauma, and when medics have been pumping massive volumes of blood and plasma into the veins to keep them alive, the tissues of the body respond by swelling enormously. The intestines, the liver, the stomach, they become engorged with fluid. They literally expand like balloons.
So the internal organs are swelling.
Now, if a surgeon attempts to forcefully pull the abdominal muscles closed and stitch them tightly over those massively swollen organs, they are turning the abdomen into a high-pressure cooker. As the organs continue to swell against the tight stitches, the pressure inside the belly becomes immense. It pushes upward against the diaphragm, making it impossible for the lungs to inflate.
So they can't breathe.
And worse, the pressure crushes the inferior vena cava, the massive vein that returns blood from the legs back to the heart.
So the high pressure in the stomach literally chokes off the blood return, and the heart pumps dry and stops.
Exactly. Abdominal compartment syndrome is rapidly fatal. So, to prevent it, the surgeons deliberately leave the abdomen open. They cover the exposed internal organs with a temporary closure device, usually a specialized medical vacuum dressing that pulls fluid away and protects the bowel from the environment, and they leave the tension completely off the system.
But the analysis mentions there is also an information management reason they leave the abdomen open, which brings us to a procedural detail that feels so profoundly human amidst all this technology.
Yes, this is fascinating.
They leave it open partially to ensure that the next surgeon at the higher echelon hospital in Germany or the US has full visibility of the injuries. And to communicate with that next surgeon, they use a surprisingly low-tech tool.
Yes, the surgeon will literally take an indelible marker, a Sharpie, and write the surgical interventions they just performed directly onto the patient's skin, right on the chest or next to the open wound.
They write the medical chart on the patient's body.
They do. In the civilian world, a surgeon dictates a detailed operative note into a pristine electronic medical record system that instantly transmits to the next doctor.
Right.
But in combat, the electronic system might go down, the server might not sync. If they write it on a piece of paper and tape it to the stretcher, that paper will get soaked in blood or literally blown away by the rotor wash of the medevac helicopter.
But writing clamped left iliac artery in black permanent marker on the patient's chest survives the chaos.
It is a fail-safe communication tool. It ensures that when the patient arrives at the major hospital in Germany 12 hours later, the receiving surgeon looks down and instantly knows exactly what temporary fixes are hidden inside that open abdomen.
Let me ask you about the psychology of the surgeon here, because it feels so visceral. You are a highly trained professional. You are deliberately leaving a patient's abdomen wide open, scribbling on their chest with a Sharpie, and pushing them back out the door onto a loud helicopter.
It's hard.
It must require an unbelievable amount of discipline to stop operating. Every instinct of a doctor must be screaming to finish the job and make the patient whole again.
It requires a fundamental rewiring of the surgical ego. Surgeons are, by nature and training, perfectionists. They're fixers. They want to solve the anatomical puzzle and close the patient up perfectly.
Right.
But damage control surgery demands that you suppress that ego. You must accept an ugly, incomplete, temporarily open wound as a clinical victory. The Sharpie marker on the skin is the perfect emblem of this entire system.
How?
It is an acknowledgement by the surgeon that they are not the savior. They are merely one link in a much longer, chaotic chain of survival.
That is a powerful realization. You aren't the hero finishing the story. You are just keeping the story going for one more chapter.
Exactly.
Which brings us to the final, incredibly advanced intervention mentioned in the analysis for dealing with that non-compressible torso hemorrhage when the patient is actually in the surgical setting.
Right.
We talked about the external junctional tourniquet and the expanding foam in the field, but when they are in the tent, they have a tool called REBOE.
REBOE. It stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. It is one of the most significant advancements in extreme trauma care of the last decade.
What does it do?
It allows a surgeon to stop massive internal bleeding without immediately cracking open the patient's chest with a bone saw.
Crack open the chest. Why would they need to do that?
Historically, if a patient arrived with massive catastrophic bleeding in the abdomen or pelvis, the surgeon had to perform a resuscitative thoracotomy.
What is that?
They would literally use a saw to open the rib cage, reach their hands deep into the chest cavity, find the aorta near the heart, and manually clamp it shut with surgical pliers to stop the patient from bleeding to death while they tried to fix the stomach.
That sounds unimaginably traumatic to the body.
It is incredibly traumatic, and survival rates were abysmal. REBOE replaces that trauma with endovascular technology.
Explain exactly how the REBOE procedure works, step by step.
When the heavily bleeding casualty is on the table, the surgeon rapidly gains endovascular access, meaning they insert a needle and a wire directly into the femoral artery in the patient's groin.
Right into the main artery of the leg.
Yes. They then take a long, flexible catheter that has a deflated balloon attached to the very tip. They thread this catheter wire all the way up through the femoral artery, sliding it inside the blood vessels until the tip reaches the aorta, the massive central artery running down the torso.
Wait, they are flying blind inside the blood vessels?
They're using anatomical landmarks to guide them. Once they believe the balloon is in the correct position, either high up near the diaphragm to block upper abdominal bleeding, or lower down near the pelvis to block lower bleeding, they inject saline into the catheter to inflate the balloon.
And the balloon blows up inside the aorta.
It expands and presses tightly against the inner walls of the aorta. It completely, totally occludes the vessel from the inside out.
Wow. So it is an internal endovascular tourniquet. You were just shutting off the main water valve from the inside of the pipe.
Precisely. The effects are instantaneous. It completely stops the arterial bleeding anywhere below the balloon.
But what about the heart?
Crucially, it instantly shunts all of the heart's remaining blood volume and pressure upwards. It forces all the remaining oxygenated blood up to the heart muscle itself and to the brain, preventing the patient from going into cardiac arrest.
It concentrates the remaining life force exactly where it needs to be to keep the computer running. But the analysis is very careful to note that REBOA is not a permanent fix. You can't just leave a balloon blocking the aorta forever, right?
Absolutely not. REBOA comes with a terrifying ticking clock. When you inflate that balloon, you are intentionally starving the entire lower half of the patient's body of oxygen.
Because no blood is getting past the balloon.
Right. The intestines, the kidneys, the liver, the legs, they are receiving zero blood flow. This causes rapid tissue ischemia.
Ischemia meaning the tissues are suffocating and dying.
Yes. You have a very narrow window of time. The surgeon has roughly 30 to 45 minutes of artificially stabilized blood pressure.
That is not a lot of time.
In that 45 minutes, they must slice open the abdomen, dig through the pooled blood, find the actual shattered artery, clamp it, and then deflate the balloon in the aorta to restore blood flow before the organs die of suffocation. REBOA is merely a highly advanced bridge. It buys the surgeon the time they need to find the leak.
It is a technological marvel when you step back and look at the sheer scale of innovation driven by the absolute necessity of survival. It is breathtaking.
It really is.
From packing wounds with clay-impregnated gauze in the dirt while taking fire, to injecting expanding plastic foam into a shattered abdomen, to threading balloons up into the aorta to stop the heart from pumping dry.
And we haven't even touched on the logistical miracles of getting freeze-dried plasma to a medic's backpack.
Exactly. Which brings us to our final synthesis. We've spent this entire deep dive looking at how military medicine handles the most extreme, chaotic physiological crises imaginable. The monumental shift detailed in Nielsen and Watson's 2016 analysis is crystal clear. Modern trauma care in austere environments has completely abandoned the illusion of immediate surgical perfection.
It had to. The old way was killing people.
The new way is a highly choreographed, ruthless logistical dance. It's about recognizing the true enemy. The enemy isn't just the bullet or the blast wave. The enemy is the lethal triad. It's that terrifying biological cascade of hypothermia, acidosis, and coagulopathy. And the entire system, from the moment the medic returns fire to the moment the surgeon writes on the patient's chest with a Sharpie, is designed to prevent that triad from taking over.
That is the core takeaway. If we connect this to the bigger picture, the military realized that the microscopic cellular battle occurring in the mud is just as critical, if not more critical, than the anatomical battle in the sterile operating room.
Right.
By pushing blood products like lyophilized plasma out to the point of injury, by deliberately allowing blood pressure to stay dangerously low to protect fragile clots, and by prioritizing systemic stability over pretty surgical repairs, they have managed to keep patients alive long enough to actually benefit from that 95% hospital survival rate.
And I want to connect this entire intense medical discussion back to you, the listener, right now. Because you don't have to be a trauma surgeon or a combat medic to use this. The concept of damage control, this fundamental idea of prioritizing systemic stability over definitive, perfect fixes, is an incredibly powerful mental model that applies to almost every facet of life.
It really does.
Think about a massive crisis you've faced. Maybe it's a catastrophic failure of a major project at work, a sudden, devastating financial crisis, or even a sudden breakdown in a critical relationship.
The human instinct in any crisis is always to try and fix the entire problem perfectly and immediately. We want to restore order.
Exactly.
But as we've learned from trauma medicine, trying to perform the perfect, meticulous repair while the system is actively bleeding out and crashing will only accelerate the failure.
Exactly. Sometimes your absolute first move shouldn't be to solve the whole problem. Your first move needs to be damage control. Stop the massive bleeding, isolate the damage, secure the perimeter.
Buy some time.
Allow the situation to stabilize, even if it looks incredibly messy and unresolved, like leaving the abdomen open. Just buy yourself the time to survive the initial shock so you can execute the definitive repair later when you actually have the resources, the environment, and a clear head to do it right.
It is a profound lesson in triage, discipline, and restraint. Sometimes, ugly survival is the prerequisite for perfect recovery.
Ugly survival is the prerequisite for perfect recovery. I love that. But as we wrap up, if we pull this all back to the medical reality of the analysis, this entire discussion raises a very important final question.
What's that?
We have spent an hour discussing how the military has definitively proven that pushing whole blood and freeze-dried plasma directly to the point of injury saves lives. We know the cellular mechanics of it. We know that pumping trauma patients full of clear saline causes the lethal triad, destroys clotting, and actively kills people.
The data is unequivocal. The military has paid for this knowledge in blood over 2 decades of conflict.
So the provocative thought I want to leave you, the listener, to mull over tonight is this. If military medicine has overwhelmingly proven this to be true in the most austere, dangerous, logistically impossible environments on the face of the earth, how long will it take before our civilian infrastructure catches up?
That's a great point.
How long before the ambulance that responds to a car crash in your own city stops pumping victims full of deadly saline and starts acting like a mobile blood bank, bringing freeze-dried plasma and whole blood directly to the streets?
It is a haunting question because the science is already there. The barrier
Yeah.
now is just logistics, funding, and breaking old civilian habits.
Because when the lights go out and the chaos starts, whether you are in a combat zone halfway across the world or on a civilian highway 10 minutes from your house, the human body's chemistry does not care about our old medical traditions. It only cares about survival. And sometimes you have to throw the old expectations of perfect sterile control entirely out the window just to keep the system from shutting down.